Michael Millis, a professor at Harvard and from Boston, who's been really an American leader and proponent in bringing PAO and the understanding of hip preservation surgery to North America. Mike.
Thank you, Dennis. It's a pleasure to be here and to follow two true masters in the field. This session is outlined outcomes, and this is not exactly a talk on outcomes. It is my initial venture into an area which orthopedic surgeons do not often venture, but probably should, because it massively seems to affect the outcomes. So this deals with the expectations of PAO patients whom young Joe Kim and I have operated on. We have no disclosures relevant to these studies. The goals of PAO are immediate short-term to improve pain and improve function, and long-term, of course, to maintain the native hip joint and not compromise future arthroplasty. The assessment of the results by the patient is a little different from how we would assess things. They're looking at benefits in terms of their symptoms and function, and clearly we've evaluated this in our studies. They look at things in terms of costs, not necessarily as time in hospital directly, but out of work, the time till full recovery. Money in terms of loss of pay, costs of other resources expended. Subjectively in terms of pain and suffering, the morbidity of the treatment. And was the operation worth it? And satisfaction is clearly one term for this. So what determines patient satisfaction? Are expectations being met? What about their post-treatment status, objectively in terms of their strength and their perceived range of motion, et cetera? Subjectively, there are PROMs that are looking at these things, very well known in the UK. Pain and function are aspects of this. And in this area, it seems that total hip replacements are more successful than total knees. But this area has not been explored very much in hip-preserving surgery. There are some facts. It seems that expectations are an important determinant in whether the patient thinks treatment has helped the problem. And it's clear that expectations of different patients are different. We surgeons often do not know, number one, what the patient most wants from treatment. Number two, what he or she understands about his problem. Number three, what they understand about possible treatments. And number four, what they are most worried about. So, looking at the literature, there have been many studies of THR, and patient expectations in this area are often overly optimistic. There's a correlation of unfilled expectations with poor patient satisfaction. In the one paper that seems to look at this in hip preservation surgery, looking at FAI patients at the Schultes Clinic, more than 50% of the patients overestimated their results in terms of pain relief, and for them, sports ability and activity level were more important. There was a strong relation of unmet expectations with poor satisfaction. And in this paper by Manning et al., it was entitled Fulfillment of Patient-Related Expectations Predicts the Outcome of Surgery for Femoral Acetabular Impingement, an important paper. So this study of PAO patients is the first, I think, that's been done on PAO patients. So our objectives were to assess the agreement in the expectations of the patients and the surgeons of what the outcomes were going to be of PAO surgery, and to examine, if we could, the relationship between the patient's perceived fulfillment of expectations and the patient-related global treatment outcome, which is a simple measure that Klaus-Peter Guenther referred to earlier today. GTO is a 5-point Likert scale. The surgery was rated by the patients as either being extremely helpful, helpful, neither helpful nor unhelpful, unhelpful, or extremely unhelpful. So the methods were to give a pre-op questionnaire to our patients and to young Joe Kim and me between 2012 and 2014. And there were 6 domains that we and they assessed in terms of pain, stiffness, locking or catching, stability, walking ability, and sports. And then the realistic expectations were rated on a 4-point Likert scale. The UCLA and HOOS were completed by patients as per our standard protocol. And the postoperative questionnaire was completed by the patients at 6 months and 1 year, and we attempted to get from there a GTO rating relating to their perceived fulfillment of expectations for improvement. We looked at the concordance between the patient's expectations and ours, evaluated by percent of exact and partial agreement, or partial agreement within one ranking, and then tried to correlate this with the global treatment outcome and the fulfillment of the expectations assessed. The results came from 72 comparable pre-op responses from the patients and surgeons, preoperatively, 59 responses at 6 months and 64 at 1 year. And in summary, this was our typical patient group. Pre-op age was about 26, sex mostly female, prior hip surgery on a minority of the patients, WOMAC stiffness 4, WOMAC pain score median 7, and use activity score pre-op mean of 6. The results, again, a busy slide, but this looks at concordance between patients and surgeons' expectations. And as I'm going to point out to you, there wasn't all that much correlation. You know, we often disagreed. It seemed to be in pain, though, there was most agreement. The patients, it turns out, most wanted relief from pain, and that's what Young Joe and I thought that we would be most likely to give them. Well, who expects more? Well, you know the answer already. The patients expect more. The patient expected more than the surgeon in almost every category, and it was only a very few times where the surgeon expected more than patients. In terms of fulfillment of expectations, at 6 months and looked at 1 year, hip pain, the concordance was close, and the expectation was largely fulfilled about 71% of the time, walking ability 68% of the time, hip stability similarly, and less fulfillment of expectations in terms of particularly ability to participate in sports. But it turns out probably this is not as important to most PAO patients as it has been in the FAI patients. Global treatment outcome and fulfillment of expectations. Again, we haven't worked this through as well as I'd like to, but the fact is that there was a correlation, some degree, between fulfillment and expectations and their global treatment outcome. In other words, in this group of patients, as with the FAI patients at Schultes, it seems like if their expectations are fulfilled, then they're going to be satisfied. The results summarized are these. The agreement between surgeons and patients was lowest regarding hip stiffness and highest regarding expected hip pain. In other words, the patients expected magically to have their stiffness get better, even though with PAO, we probably don't usually increase their range of motion, but somehow the patients felt that they should get more motion out of this. Everybody thought that the pain should be better, and it turns out we're fortunate because we usually made the pain better. In instances of disagreement, the patients consistently had higher expectations than the surgeon, as I mentioned, especially with respect to stiffness, walking ability, and locking or catching. They still perceived some locking or catching some of the time, although it seemed to bother them not so much. Fulfillment of expectations for sports, pain, and stability were most correlated with the global treatment outcome at 6 months. The fulfillment of expectations of walking ability were most correlated with global treatment outcome at 1 year. So in conclusion, this is obviously a preliminary study in an area where we don't know a lot. Patients are usually more optimistic than their surgeons about outcomes of PAO for every symptom domain addressed in this study. There's a significant discrepancy between the patient and surgeon expectations, particularly for hip stiffness, locking, and sports. And pain seems to be primary concern to the patients, and they are close to their expectations in their surgeons regarding pain. And fortunately, we usually have been able to help their pain, at least in the short run. In terms of future studies, we want to collect postoperative data at 2 years, 5 years, and 10 years. We want to understand the relationship to global treatment outcome better, and we also, of course, want to conduct a trial to assess the effect of specialized preoperative education on the expectations of patients and their subsequent satisfaction. Thank you very much.
This is a difficult field. Some have said every patient wants their surgeon to be a Donald Trump. If I operate on you, you will have a great result. We expect things to be fantastic, and particularly in sports medicine, that you will be able to return to every possible sport. And if you don't give them this message, then they might not come to see you. So we'll have to see how we dig out of this. Every great center and great surgeon has to figure out who is going to follow them in their center. And fortunately in Boston, Dr. Millis was able to pick his colleagues who would follow him, and usually you do it best by having a surgeon who trained in your center and you know his character. And so one of the leading surgeons in the world now for the PAO and hip preservation surgery is Dr. Young Jo Kim from Boston, who's going to speak with us about high range of motion demands, dancers, cheerleaders, etc. I believe I'm reading this correctly. Young Joe.